Good day, everyone. So, for our group's discussion for today, we will be tackling endometriosis.
What is endometriosis? Endometriosis is a common gynecological condition that usually affects the ovaries, fallopian tubes, and the tissue lining the pelvis. It happens when tissue that is similar to the tissue lining the woman's uterus grows outside of the uterus. The tissue responds to hormones that affect the menstrual cycle in the same way that endometrial tissue does. It swells and bleeds like endometrial tissue, but there is nowhere for the waste tissue and blood to go. This leads to inflammation and swelling to its surrounding areas. There are three main types of endometriosis based on its location, namely superficial peritoneal lesion, endometrioma or ovarian lesion, and deeply infiltrating endometriosis.
At this juncture, we will now tackle about the precipitating factors. First, we have hypoxia. Second is iron deficiency, which may contribute to the early onset of endometriosis. Third is pelvic infection. Fourth is uterine abnormalities. And lastly, we have medical conditions that prevent menstrual blood from flowing out of the body normally.
Here are the predisposing factors that may increase the risk of endometriosis. First is female gender. Endometriosis is a common gynecological condition affecting the reproductive organs of a woman. Next is menstrual cycle. It can affect a menstruating woman from the time of her first period to menopause. Next, early menarche is a pivotal factor of endometriosis risk, which supports the potential role of abnormal hormone secretion and endometrial stem cell transplantation in the pathogenesis of disease. Another is short menstrual cycle less than 27 days and long duration of menstrual flow greater than 7 days. Next is family history. If someone in the family has endometriosis, the odds of developing the condition is 7 to 10 times greater than a woman who has no family history of the disease. Another is age. Endometriosis is largely confined to women of reproductive age with an active hypothalamic pituitary ovarian axis. It typically occurs in women aged 25 to 30 years. And the last is delayed childbearing. Women who delay their childbearing would seem to be more susceptible in having the disease.
Signs and symptoms. The following are the most common symptoms for endometriosis, but each woman may experience symptoms differently, or some may not exhibit any symptoms at all. Symptoms of endometriosis may include painful cramping similar to menstrual cramps, long-term lower back and pelvic pain, periods lasting longer than 7 days, heavy menstrual bleeding, bowel and urinary problems including pain, diarrhea, constipation and bloating, blood in the stool or urine, nausea and vomiting, fatigue, pain during sex, spotting or bleeding between periods, difficulty becoming pregnant or infertility. Sometimes endometriosis is first diagnosed in those seeking treatment for infertility. It is important to note that the amount of pain a woman experiences is not necessarily related to the severity of the disease. Some women with severe endometriosis may experience no pain, while others with a milder form of the disease may have severe pain or other symptoms.
From the information given by reliable internet sources, endometriosis affects women mostly in their reproductive age, as in from the onset of their first period or menarche to their last, which is menopause. While the condition is clearly described, there are theories about how this really occurs histopathologically. Some theories are retrograde menstruation and something about hormones. But to begin with a simple explanation, in terms of the retrograde menstruation, during menstruation, normal endometrial tissue is shed and passes through the cervix with the menstrual blood. Unbeknownst to us, in some women, menstrual blood and endometrial cells flow through the fallopian tube into the abdomen. Endometriosis can happen when the endometrial cells in the menstrual blood cannot detach from the wall of our other female body parts, and this grows into an area that they are stopped. After the endometrial tissue grows into the area outside the uterus, it still responds to hormones and that sheds off, but the blood from the shedding outside the uterus cannot leave the body, causing irritation that leads to inflammation and pain in the area that is stuck. There are also scar tissues called adhesions that may form, sticking one organ to the other, leading to possible closing of the fallopian tubes. Endometriosis can also cause endometriomas or cyst in the ovary, and these conditions can cause infertility. In some cases, endometriosis can cause abnormal bleeding. Because endometriosis can occur in the areas around the female reproductive system, some symptoms can actually be felt in the pelvis. There are four stages of endometriosis, and this is used in describing the location, depth, and size of the endometrial tissue. Specific criteria include the extent of the spread of the tissue, the involvement of the pelvic structures in the disease, the extent of pelvic adhesions, and the blockage of the fallopian tubes. In stage 1 or minimal, there are few small implants or small wounds or lesions. They may be found in your organs, on the tissue lining your pelvis or abdomen. There's little to no scar tissue. In stage 2 or mild, there are more implants than in stage 1. They are also deeper in the tissue and there may be some scar tissue. For stage 3 or moderate, there are many deep implants. You may also have small cysts on one or both ovaries and thick bands of scar tissue called adhesions. In stage 4 or severe, this is the most widespread. You have many deep implants and thick adhesions. There are also large cysts on one or both of your ovaries. That would be all for the disease process.
The tests to check for physical clues of endometriosis include pelvic exam. During a pelvic exam, your doctor manually palpates areas in your pelvis for abnormalities, such as cysts, because often it's not possible to feel small areas of endometriosis unless they've caused a cyst to form. Transvaginal ultrasound. This test uses high-frequency sound waves to create images of the insides of your body, which can identify cysts associated with endometriosis. Magnetic resonance imaging. An MRI is an exam that uses a magnetic field and radio waves to create detailed images of the organs and tissues, giving the surgeon detailed information about the location and the size of endometrial implants. Laparoscopy. Under general anesthesia, your surgeon makes a tiny incision near your navel and inserts a slender viewing instrument called a laparoscope. This looks for signs of endometrial tissues outside the uterus. A laparoscopy can provide information about the location, extent, and the size of the endometrial implants. CA125 test. This is a blood test that checks the levels of a blood protein known as CA125, but is also used to detect a specific protein found in the blood of women who have endometriosis.
The nursing diagnosis of endometriosis includes: first, chronic pain related to pressure of concealed bleeding and formation of adhesions. The patient may feel the pressure of concealed bleeding through abdominal cramming. Chronic pain is also felt since endometriosis can cause a chronic inflammatory reaction resulting in the formation of scar tissue or adhesions. This is possibly evidenced by verbal reports, a pain score of 10 out of 10, guarding behaviors, irritability, and narrowed focus. Second, impaired physical mobility related to reluctance to initiate movement, secondary to pain. The patient has limited independent, purposeful physical movement of the body or of one or more extremities due to a reluctance to initiate movement, thinking that it will only cause more pain. This is possibly evidenced by verbal reports, a pain score of 8 to 10 out of 10, and disinterest in ADLs due to pain. Third, sexual dysfunction related to associated condition of altered body function. Patient's sexual desire is affected by her loss of libido, presence of adhesions, and painful menses. This is possibly evidenced by verbalization of undesired change in sexual function or desire. Lastly, deficient knowledge regarding pathophysiology of condition and therapy needs related to lack of information. This is possibly evidenced by statements of concern and misconceptions.
For the healthcare management, currently there's no cure for endometriosis. Treatments usually include surgery or medication. First is pain medicine. The doctor may recommend an over-the-counter pain reliever. Non-steroidal anti-inflammatory drugs like ibuprofen or naproxen work for many people. Next is hormones. Hormonal therapy lowers the amount of estrogen the body creates and can stop the period. This helps lesions bleed less so there's not much inflammation, scarring, and cyst formation. Common hormones include birth control pills, patches, and vaginal rings, gonadotropin-releasing hormone, agonists and antagonists. Next is progestin-only contraceptives, and danazol. Then there's surgery. The doctor might use a laparoscope or do a standard surgery that uses larger cuts. In the most severe cases, there's a surgery called hysterectomy to take out the ovaries, uterus, and cervix. These are some lifestyle changes for treatment of endometriosis. First is balanced diet. Research has shown a link between endometriosis and diets that are low in fruits and vegetables and high in red meat. Next is exercise regularly. Working out encourages the heart to pump blood to all the organs, improve circulation, and help nutrients and oxygen flow to all of the systems. Lastly, manage stress. Researchers think stress can make endometriosis worse. In fact, the condition itself might be the cause of the stress because of the severe pain and other side effects.
And that is all for our concept map of endometriosis. Thank you for listening.